Hello everyone. Today we'll try to understand an important concept, that is the basic pathophysiology and tetralogy of Fallot. So if you understand the underlying pathophysiology, you need not by heart its components, clinical features or its management. The video is going to be very interesting and informative, so please watch till the end. So let's get started. So we all know that the components of TOF are number 1, ventricular septal defect, overriding of aorta, right ventricular outlet obstruction, which is most commonly in the form of infundibular stenosis, and right ventricular hypertrophy. So what do you think? Are all these things just occurring randomly together or there is something else? Let's see. So before understanding TOF, let's just quickly recap the basic orientation of heart, which is most important for understanding the pathoanatomy. When we study the hemodynamics of heart, usually we draw this diagram. Okay, that is both atria lying side by side, the ventricles below them, and the interatrial and interventricular septum in the midline, which is actually not so. Now this is the actual orientation of the heart as it is placed in the mediastinum. The right atrium is on the right ventricle is placed anteriorly and to the right, the left ventricle is situated mainly to the left and posteriorly, whereas the left atrium is placed posterior and above the left ventricle. Now in this picture, we have opened the anterior wall of the right ventricle and we are seeing from the front. Here you can see that the right ventricle inlet is placed side by side to the right ventricle outlet. The blood flows from right atrium to right ventricle through the tricuspid wall and from the right ventricle into the pulmonary artery. If you place your right hand on the interventricular septum, the thumb will be directed towards the right ventricular inlet, whereas the direction of other fingers is towards the right ventricular outlet. So again here in this diagram, we have opened the anterior wall of the right ventricle and we are seeing from the front. Here you can see the tricuspid wall, the papillary muscle strips that are attached to the tricuspid wall leaflets. The rough part of the right ventricle is the one which has multiple trabeculations, which are also nothing but the muscle fibers. Among them, the most important ones are the septomarginal trabeculations and the septoparietal trabeculations. These are called so because they are in close relation with the interventricular septum. The part of the septum which is just below the opening of the pulmonary artery is called the conus, also known as the infundibular septum or the outlet septum. All these structures are important to understand the pathophysiology of tetralogy of Fallot. Till now, we were seeing the heart from the front. Now in this picture, we have taken a horizontal section across the heart and seeing it from above. Just to orient you with this picture, this is the anterior aspect, the posterior aspect, this is the right and this is towards the left. Here we can see that the right ventricle cavity is placed anteriorly and to the right, whereas the left ventricle cavity is situated posteriorly and to the left. The interventricular septum, as you can see, is not a midline structure but is placed in this manner. The opening of the pulmonary artery and its relation to the aortic opening can also be seen. This part of the septum, which is located just below the opening of the pulmonary artery, is nothing but the conus or the infundibular or the outlet septum that we saw in the last picture. This is outlet septum because it is located near the right ventricular outlet. Here you can see this is the interventricular septum, the right ventricle cavity, left ventricle cavity. Here is the site of tricuspid valve located behind the pulmonary artery opening, and this is the site of mitral valve. Now, after understanding this basic orientation, it will be very easy to understand the basic problem in TOF. TOF is not due to 4 different things happening in random. Okay, there is a single defect, that the anterior and cephal head or the upward displacement of the infundibular or outlet septum along with hypertrophy of the septomarginal and septoparietal trabeculations. Now this deviation or displacement is due to dysplasia or hypoplasia of this part of septum that occurs during its development. Now what problem will this displacement cause? As the septum is hypoplastic and displaced anteriorly, there is resulting defect in perimembranous area of interventricular septum, which is the VSD, which is our first component of TOF. As the VSD is because of the malalignment of the infundibular septum with respect to rest of the septum, this is called an anteriorly malaligned VSD. This anterior deviation will also cause a compression over the pulmonary artery opening, which leads to right ventricular outlet or the outflow obstruction, which is our second component. The right ventricular outlet obstruction may also be due to the pulmonary artery stenosis or the hypoplasia or atresia, which usually occurs along with dysplasia of the septum. Now, this RVOT obstruction causes the right ventricle to contract more forcefully to pump the blood into the pulmonary artery against the obstruction. Over time, this RV pressure overload leads to hypertrophy of the right ventricle muscle fibers. Now, as the septomarginal and septoparietal trabeculations are also a part of RV muscle, they also get hypertrophied, which further adds on to the RVOT obstruction. The anterior displacement also results in aortic overriding, as you can see in this video. That is, some part of the aorta opens into the left ventricle cavity and some part opens into the right ventricle cavity. So as we have already discussed, the RVOT obstruction, which is most commonly due to stenosis of the infundibular area, it can also be caused due to pulmonary atresia or hypoplasia or stenosis of the pulmonary artery valve or hypoplasia of the pulmonary artery itself. When present, these are known as staph variants. Though the factors causing RV outlet obstruction may be different, the physiology, that is a combination of VSD with RVOT obstruction, remains the same, and this is called as staph physiology. This is also seen in other conditions, for example, DORV with PS, that is double outlet right ventricle with pulmonary stenosis. DORV is nothing but the right ventricle has two outlets, that is double outlet, that is one is the pulmonary artery and second is the aorta. In other words, even in DORV, the aorta is opening both in right ventricle and left ventricle. The difference between TOF and DORV is that in TOF, the degree of overriding of aorta is less than 50%, whereas it is more than 50% in case of DORV. So in summary, the deviation of septum along with pulmonary stenosis lead to right ventricular outflow obstruction, which causes compensatory hypertrophy of the right ventricle and the trabeculations, which further causes increased obstruction, and this vicious cycle goes on. The hypertrophy of the right ventricle leads to increased pressure in the right ventricle, which at a point of time exceeds than the pressure in the left ventricle, which leads to shunting of the blood from right ventricle into the left ventricle through the VSD. This right to left shunt along with RVOT obstruction lead to cyanosis, which is progressive in nature as the child grows. Hope this video has cleared your concepts about the basic underlying pathology in tetralogy of Fallot. Thanks for watching, and watch out for the video on the hemodynamics in TOF and cyanotic spell. Meet you in the next video. Till then, happy learning.